Hi, my name is Joe Bellick, and I'm the founder of Bellick Law, LLP. We are proud sponsors of the Mesothelioma Research Foundation. We have been honored to do this work for 25 years, representing people with mesothelioma and their families. And part of our commitment to our clients is to give back and sponsor research and advocacy efforts and engagement across the mesothelioma community.
Hi, I'm Trey Branham. Dean Omar Branham and Shirley is proud to sponsor this year's Mesothelioma Applied Research Foundation Conference. The 34 lawyers at Dobbs have more than 400 collective years providing legal representation to victims of this insidious cancer. We applaud the leadership of MARF and this community for its tireless dedication to finding a cure for this totally preventable disease.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
Welcome to this episode of Meso TV. I'm Julie White, and I'm the Director of Patient Services here at the Meso Foundation. And today I'm welcoming Dr. Aaron Mansfield of the Mayo Clinic. Dr. Mansfield is a medical oncologist who focuses on thoracic cancers and tumor immunology. Today we are focusing on his work in mesothelioma specifically. Dr. Mansfield, you've done research in the areas of both pleural and peritoneal mesothelioma. I wanted to start today with talking about the term multimodality, easy for me to say, treatment. This is a term that's often heard when we're describing mesothelioma treatment. Could you explain what this term means and why it's used when we're talking about mesothelioma treatment?
Yes, of course. And first, thank you for having me back, Julie.
Of course.
It's nice to connect with the foundation again.
Yeah.
So multimodality means we're using more than one modality. And as a clinician, the way we think about that is that we're involving multiple different experts. So I'm a medical oncologist, and I specialize with giving the drugs, be it the chemotherapies, the immunotherapies, or targeted therapies. But multimodality means that I'm integrating that therapy with surgery or radiation typically. And for the trials we're talking about today, we're giving immuno or chemoimmuno before a patient would go to surgery. So in these situations, we're working hand in hand with a different type of expert than what I am and many of my colleagues are.
Okay, great. So today we're going to talk to Dr. Mansfield about a couple trials that are ongoing at the Mayo Clinic. Dr. Mansfield leads up and writes and does a lot of work with clinical trials and has done a lot. Specifically today, I wanted to start with asking you about a phase 2 study that you have ongoing, which is called Testing the Addition of Immunotherapy Before Surgery for Patients with Sarcomatoid Mesothelioma. And first I wanted to clarify, this is for pleural patients, correct?
Correct. This study is for patients with pleural mesothelioma.
Okay. And this is a phase 2 study. Could you explain to us what a phase 2 study is?
Yeah, of course. So I'll give that answer by providing what a phase 1 study is and then talking about phase 2. Typically, we describe clinical trials as being a phase 1, 2, or 3. And in a phase 1 study, we're often using a drug or a drug combination for the first time, and we're trying to determine its safety. Of course, we always want to see if it's effective and helps our patients, but these studies often involve giving escalating doses of a drug to make sure that it is safe. And then what we learn from the dosing of those studies can then be used in a phase 2 study where we're really looking for signals of efficacy. So for the study we're talking about here right now, we're not escalating the doses or exploring different dosing combinations. That work has been done. We're now asking questions about how well an established dose of a combination works in pleural mesothelioma?
First, we don't see many trials that are focused on patients with sarcomatoid or biphasic cell type mesothelioma. That's pretty rare. Let me back up and ask you, though, if you could explain. Some people aren't aware of what cell type or histology means. Could you go through the basic types for us?
Yeah, so in mesothelioma, we typically break it down into three subtypes. It could get a little more complicated, but these three are the best way to think about it. And this describes how the cells look beneath the microscope, is sort of their size and shape. And we classify mesothelioma by whether they're epithelioid, sarcomatoid, or both, and the term for that is biphasic. So as a pathologist will get a sample of mesothelioma from a biopsy or surgery and put that beneath the microscope, he or she may come back to us and tell us they think it's one of these types or the other, or a mixture of the both based on, again, the size and shape.
And it's called for patients with sarcomatoid mesothelioma, but are only sarcomatoid patients allowed to enroll in this trial?
So this study was written mainly for patients with sarcomatoid mesothelioma and those with biphasic, meaning they have that sarcomatoid component.
Mm-hmm.
The early accruals have almost exclusively been for those patients.
Mm-hmm.
We have opened this study to allow any histology into the trial at this time.
Oh, okay. So epithelials is allowed as well. I understand. Right. Yes. Okay. Second, another thing that makes this trial different is that you're talking about surgery. And generally speaking, most patients that we hear having surgery for pleural mesothelioma are generally that epithelial cell type that you're speaking of. Can you explain why the study would be focusing on the sarcomatoid and biphasic with surgery?
Yeah, I'd be happy to. And surgery has become a very hot topic in mesothelioma, or a cold one if you want to use that metaphor instead. Typically, patients with sarcomatoid or biphasic mesothelioma have not been offered surgery. And what we've seen going back about 5 years with the approvals of frontline dual immune checkpoint inhibitors with the ipilimumab and nivolumab is that patients with non-epithelioid disease are doing really well, almost as well as patients with epithelioid disease. And this has been a real game changer for this histology. Historically, when you look at our era of chemotherapy, patients with biphasic or sarcomatoid disease do not do as well with chemotherapy as patients with epithelioid mesothelioma do. And for that reason, because immunotherapy has changed that thinking, we wanted to figure out the safety and put some data around whether these patients should be offered surgery or not. Historically, they have been excluded because of poor outcomes that we've seen in the prior trials.
Oh, okay. So this might end up being paradigm changing depending on how the outcomes are. It could be.
So because this is a phase 2 study, it's not a phase 3 randomized study comparing surgery versus no surgery. We're trying to establish the feasibility and ask, and just again state, hey, this patient population typically has not been offered surgery, but in this era of immunotherapy, as we're seeing their outcomes improve, should we question that paradigm and start to offer them surgery after they've had immunotherapy and hopefully a response to it? And should we rethink this moving forward? So the hope at the end of this study is to say that the patients got immunotherapy, they tolerated it well, they were able to go to surgery, and they tolerated the surgery well and recovered well from that, and had durable control of disease because of this multimodal approach. That's the hope, and then it would hopefully lead to a larger study.
Phase 3 study.
From there.
I understand, yes. So could you lay out sort of how the study is designed for us and what would happen if a patient was to enroll in the study?
Yes. So this study is written for patients who are newly diagnosed.
Okay.
We want to capture patients before they have been treated with any IV therapy, be it chemo or immuno or the combination, or before they've had a major surgery. The question here is whether patients with newly diagnosed mesothelioma can get immunotherapy and then go to surgery. And again, with that emphasis on the non-epithelioid histology, although any histology is allowed. So the idea here is patients who are diagnosed would come to a center that has the trial open. The diagnosis would be confirmed, and they would have a full adequate staging. We want to make sure that there's not disease in the opposite side of the chest or in the peritoneum. We don't think that surgery is meaningful to offer in that setting. So we, again, want to confirm the diagnosis, make sure the disease has not spread beyond one side of the chest, and that it still makes sense to consider surgery in that setting. I sort of alluded to earlier that surgery has been questioned in mesothelioma. Some of us think we should still be offering it, but in the setting of appropriate staging.
Yes. And what immunotherapy drugs are you giving the patient?
So the immunotherapy we're giving in this study is based on the Checkmate 743 study. The majority of guidelines globally, and especially the ones in the United States, say that patients with non-epithelioid mesothelioma should get ipilimumab and nivolumab, again, based on the randomized phase 3 clinical trial Checkmate 743, which showed that this regimen was superior to chemotherapy, but especially for this non-epithelioid group. So everyone would be getting the standard of care, a systemic immunotherapy by going on the study.
Yes.
At the end of a few cycles of the immunotherapy, we get imaging to see whether the disease has shrunk or not. And then if it still makes sense, the surgeons would offer surgery at that point. But we do engage the surgeons at the beginning of trial enrollment to make sure that this is someone they would potentially operate on should everything go well, as I just described.
So every patient may not go to surgery depending on the outcome of the immunotherapy treatment.
Correct. So sometimes, unfortunately, immunotherapy does not work, and the disease will progress. In that situation, surgery would not be offered. Sometimes there's a complication from immunotherapy, or sometimes as a patient thinks about it more, they prefer not to undergo surgery. So a patient would always have a right to decline moving forward with that. And if we think that the disease has changed on imaging to an extent where it no longer makes sense, the surgeon would still be able to say, that it's not appropriate to go to surgery at that time.
Right. Moving back to the immunotherapy, many people are aware of the Yervoy, Opdivo, ipilimumab, nivolumab, whichever term they're familiar with, as their standard of care, as you said, now for first-line treatment. But just in case anyone is not or is listening in, this is new to them, could you just briefly go over the type of drug they are and how they work, and then just the basic side effects profile that they might have?
Yeah, of course. So these two drugs are different than our traditional chemotherapies. These are antibodies, and these antibodies have been designed to target what we call checkpoints, but these are proteins on the surface of the tumor cells or the immune cells, or different components of the immune system. And because these antibodies bind to these checkpoints, what it does is it reinvigorates the immune system to attack the tumor. To put that another way, the tumor can express proteins that shut down our body's immune response against the tumor. And because we figured out what some of these checkpoints are, these antibodies can mask them so that it will disinhibit or reinvigorate the immune system. And we've seen really dramatic changes in patients' tumors because of these drugs, not just in mesothelioma, where this combination is one of the standard of care options, but in lung cancer and all sorts of cancers, we've seen these drugs provide benefit. There's a lot of nuances to which subset of these different cancers, but These immune checkpoint inhibitors have been a major game changer across all of oncology and many different types of cancers, having shown response to these drugs. Now, the problem with these drugs, though, is because they do stimulate the immune system. It's nice when it's only directed against the tumor, but sometimes the immune system will then attack our own body. And sometimes these side effects are relatively minor. Some of the most common things we see are some issues with the thyroid or some rash on the skin. Every now and then the liver gets a little upset and the enzymes from the liver track upwards. Most of these are typically reversible and controllable. Other times, less commonly though, we see really severe immune reactions against the lungs, the colon, where people have difficulty breathing or get really bad diarrhea. The list goes on, but essentially the biggest concerns about these drugs are autoimmune-like or immune-reactive side effects driven by the immune response.
Yes. I also hear a lot of patients tell me that they get what's called the arthralgias, myalgias, the achies.
Yeah, that's another side effect. I didn't list them all. Some patients we unmask or we worsen a pre-existing rheumatologic condition where they may have some rheumatism or another inflammatory condition already. And then if you give these drugs, we're very likely to worsen it.
Okay. Another question, I'm jumping around a bit, but going back to the surgery, you're a medical oncologist, so you're working again with the multidisciplinary, but who would be performing the surgeries if the patient was to go to surgery?
Yeah, so it would not be a medical oncologist like myself, but here and at many other centers, we work hand in hand with thoracic surgeons. So here we have a large team. As a part of this trial, Dr. Dennis Weigel's the surgical principal investigator. So he helped me write this trial and wrote the surgical end of it while I wrote the immunotherapy, systemic therapy component of the trial. So we, at our center, we have him, Dr. Reisenauer, and others who would see the patients with me at the time they enroll on the study. And then after they go through a few cycles of therapy, I would then pass the baton to the surgeons while our patients then go forward with surgery, and we follow up together afterwards. So we work hand in hand very closely.
So this trial is only open at large centers or centers of excellence where there would be a experienced surgical thoracic surgeon.
Yeah, I don't know the exact number off the top of my head, but I believe over 50 places have activated the clinical trial. The majority of them are larger academic centers, but from the West Coast to the East Coast, and throughout the Midwest, this trial is open.
I know that one of the things they talk about with thoracic surgery is that there be a physician who is experienced and has done this a number of times. That's why I was asking.
Yeah, and a part of this trial, this clinical trial is open through the Alliance, which is a part of our National Cancer Institute's National Clinical Trials Network. A lot of acronyms in there, but and it requires that surgeons have expertise in mesothelioma to be able to participate in the trial.
Good. Okay. Are there any exclusionary factors that would, other than, I know you said that this has to be their first, they have to be untreated, but is there anything else that sort of stands out that a patient, if they were thinking about this, would sort of knock them out of being eligible for this trial?
Yeah, I mentioned one of them already, and that was with the staging. We want to make sure that the disease has not spread. Let's say the mesothelioma started on the right side of the chest. We want to make sure it has not gone over to the left or into the belly. Most people would agree in that setting that surgery is probably not the most appropriate thing to offer. So this trial is looking for patients where that has not occurred. I mentioned when we were talking about the side effects, how by stimulating the immune system, we can cause these immune-related adverse events. So if someone comes in with some inflammatory conditions that are pre-existing, like a really bad Crohn's disease or some other pre-existing inflammatory conditions that our medications can worsen, that they would be excluded from the trial. So those are the major ones.
Makes sense. Well, this sounds like an exciting trial to get some really good information to help patients. So looking forward to see how this data comes out, and hopefully you'll be able to move on to a larger study. Thank you. I also did want to ask you about another trial that you're running at Mayo Clinic, another phase 2 study. I know we did interview you with Meso TV a few years back when you were just getting ready to open this trial. This was another phase 2 chemotherapy with or without immunotherapy for peritoneal mesothelioma. And I know it's been open a while now, but there are not a lot of trials specifically for peritoneal mesothelioma, as this is more rare. Pleural is a lot more common. And I realize that it takes a little longer to accrue to this because peritoneal is not as common. I wanted to bring this trial back up though, because I wanted, to let people know that it is still open. And I also wanted to have you tell us just a little about it and why it's so important to collect data and to get information on peritoneal patients.
First, it's been a few years since I presented this to Meso TV. We are, I believe it's over 80% accrued now, and we're just looking for, I think it's 12 more patients, and then we will have met our accrual goal, give or take 1 or 2. So we're almost there. We just need to make it over this last push. So it's been accruing really well for a rare variant of a rare disease. Primarily because there's almost no dedicated studies for mesothelioma. So I think that's helped drive accruals, especially with the foundation's help and referrals to centers that have this open. As you mentioned, all patients get therapy. There's no placebos here. It's just half the patients have immunotherapy added to it, added to the chemotherapy. This trial accepts patients whether they go to surgery afterwards or not. So there could be a surgical component, but if surgeons don't believe it's safe to operate, they can still go on the study. So we're taking any newly diagnosed patient with peritoneal mesothelioma, assuming there aren't those similar contraindications, like a really bad inflammatory condition coming on because we are using these immunotherapies. But to your other question, why is it important to study peritoneal mesothelioma? So much of the data we have is extrapolated from pleural mesothelioma, or great work has been done before, but a lot of that work is based on just a single institution or a few institutions piling their data together in a non-randomized fashion, and we use those data to guide our management. So we wrote this trial to really help define what medical oncologists should be doing for patients who present with this disease, and provide better guidance than what we had existing from the extrapolation of pleural disease.
Yes, and this is a great trial for anyone newly diagnosed, from what I understand, because if you're a surgical candidate, not a surgical candidate, I mean, any way it goes, right? You're going to get standard of care or standard of care plus another option, correct?
Exactly.
So you're going to get good treatment and go to surgery if you're a surgical candidate, and also help to further research on your disease. So
the study does even allow crossover to immunotherapy for the group that does not get it up front. So immunotherapy is made available to our patients in the study.
So if you get randomized to the standard of care arm, then you'll get the immunotherapy on the other end.
Yeah.
Wonderful. That's great. And like you said, only a few more slots left to complete it. So amazing. Well, you're doing great work there at Mayo Clinic, and sounds like if someone wants to participate in either one of these trials or another one that you have open, they can contact you at Mayo Clinic or get in touch with us here at the foundation, and we will get them connected with you.
Yeah, I'm happy to take any referrals, but my colleagues around the country are helping us accrue to these studies. Again, I think we said this more for the plural trial, but similarly, this study is open from the West Coast to the East Coast. So you don't necessarily have to travel to Minnesota, although our doors open to you. So
Yes.
working with Near the Foundation, if there's something available closer to you, we would be happy to point it out.
Yep. And I know you're always working on new things. So we will look forward to speaking to you again soon. And thank you, Dr. Mansfield, for your time.
Thank you, Julie, for having me back.